Okay, let's go on to case 8. All right, a 42-year-old white man comes to the office with complaints of joint pain of 6 months' duration. He was well until 6 months ago when he noticed pain in his lower back and stiffness. After periods of inactivity, it has worsened, and now he exercises every morning to loosen up his back. He describes pain throughout the day. It is non-radiating, and there are no neurologic complaints. He states recent onset of painful swelling of his left ankle and several small joints of his hand. These cause considerable morning stiffness that lasts approximately 45 minutes. His only significant past medical history is psoriasis for the past 3 years, for which he uses topical steroids on and off. So what is the most likely diagnosis in this particular case? What's the most likely diagnosis in this particular case? Psoriatic arthritis, okay? Which is otherwise known as one of the seronegative spondyloarthropathies, right? We mentioned earlier that there are 4 diseases basically that give you a seronegative spondyloarthropathy. Where they are basically ankylosing spondylitis, psoriasis, or psoriatic arthritis, Reiter's, and the arthritis associated with inflammatory bowel disease. Right? So when we talk about seronegative spondyloarthropathies, we're referring to one of these 4 diseases. We're referring to one of these 4 diseases. Now, what is characteristic of psoriatic arthritis? It's part of the differential in distal arthritis of the hands. Whenever you have arthritis involving the distal interphalangeal joint, which is asymmetric, think about psoriasis or psoriatic arthritis as a possible cause, in addition to the osteoarthritis that we discussed in the earlier case. So basically, this is a gentleman who has a history of psoriasis who comes in with lower back pain and stiffness. Now, how do we differentiate psoriatic arthritis from osteoarthritis? Can patients with osteoarthritis have low back pain from the osteoarthritis? Absolutely. So how do we make the differentiation between osteoarthritis, which can give me a distal asymmetrical arthritis, with psoriatic arthritis, which can also give me back pain and a distal asymmetric arthritis? How do we make the differentiation? Well, what are the 3 categories that we use to differentiate between all these rheumatologic diseases? We've been talking about joint pattern. And in this particular case, joint pattern doesn't really help us that much, right? Because the joint pattern can be very similar. We also talk about extra-articular manifestations, right? So what kind of extra-articular manifestations can you get in seronegative spondyloarthropathies? Seronegative spondyloarthropathies. What? Basically, you can get cardiac involvement. You can get aortic insufficiency. You can get aortitis. So if you have a patient who comes in with back pain, distal asymmetric arthritis of the hands with a diastolic murmur on exam, that's an extra-articular manifestation which speaks for a seronegative spondyloarthropathy. What else? What's the third thing that we look at to differentiate between rheumatologic diseases? Inflammation. And when we talk about inflammation, we talk about morning stiffness, or the duration of the morning stiffness. So in osteoarthritis, it would be very, very, very unlikely to have morning stiffness that lasts greater than 30 minutes. And in this particular case, he has morning stiffness, but the morning stiffness lasts how long? 45 minutes. And that speaks for an inflammatory arthritis and against osteoarthritis. So he's a young man who has back pain, and the pain seems to get better with activity. It loosens up after he exercises and gets better. He has non-radiating back pain with morning stiffness consistent with an inflammatory arthritis. Morning stiffness consistent with an inflammatory arthritis, speaking against osteoarthritis as the cause of his distal asymmetric arthritis. As a cause of his distal asymmetric arthritis. So the main point here is, first of all, he's male, right? if they would ask you on the boards, what is the only rheumatologic disease more common in males than females, the answer would be seronegative spondyloarthropathies, ankylosing spondylitis, Reiter's syndrome, inflammatory bowel disease, and the arthritis associated with psoriasis. The fact that there's inflammation and morning stiffness adds to the evidence against osteoarthritis as a cause of his distal arthropathy. And the fact that he has psoriasis also sort of is a little bit of a hint. Right? Now, patients who have psoriatic arthritis, how do they generally present? What comes first, the psoriasis or the arthritis? What comes first, the arthritis or the psoriasis? The psoriasis actually comes first in 80% of the time. So a lot of times patients will have psoriasis for many years, right? Such in our case. He has had psoriasis for the past 3 years, and he's been taking steroids, topical steroids for his psoriasis, and suddenly he's presenting with back pain and a distal arthropathy or arthropathy of the distal interphalangeal joints. Now, what is characteristic of Reiter's syndrome? What is characteristic of Reiter's syndrome? Okay, so it's the famous mnemonic, can't pee, can't see, can't climb a tree, uveitis, right? Uveitis, urethritis, and arthritis. Can't pee, can't see, can't climb a tree. I've got Reiter's syndrome. All right? That's basically how it works. And generally, Reiter's syndrome is considered to be a reactive arthritis. Patients have had some sort of gastroenteritis, some sort of viral or bacterial infection, and they're having a reactive arthritis after this infection. Right? That is Reiter's syndrome. Now, how do we treat ankylosing spondylitis? How do we treat seronegative spondyloarthropathies? NSAIDs, painkillers. Now, there is recent data that TNF-alpha inhibitors, like etanercept in particular, have been shown improvement in the pain the patients get with ankylosing spondylitis. So let's go on to physical exam and see what we find. What do you expect to find on physical exam in these patients? What do you expect to find on physical exam? Well, does anybody know what the Schober test is? What's the Schober test? Right, so you actually want to see, you can actually mark the lumbar spine, and as a patient bends over, if the distance between those two marks doesn't expand, it's consistent with fusion of the spine, and that's called the Schober test. All right? Now, how do you make the diagnosis? The diagnosis is basically made clinically, and is also made with typical radiographic findings, which we're going to go through. There's something called the dagger sign, which I'll show you. And there's also something called the tram track sign, which I'll show you. And there's also something called the bamboo spine, which I will also show you. All right? But let's go through the physical exam. So this gentleman is afebrile. Blood pressure is 120/74. Pulse is 72 and regular. And the respirations are 14 per minute. There are erythematous, dry, scaly patches of skin along his hairline. His chest is clear to auscultation and percussion. His heart has a good S1 and S2 with no gallop, lift, or murmurs. So he doesn't seem to have an aortitis or any aortic insufficiency as a complication. His abdominal examination is normal. Examination of the extremities shows small punctate lesions of the fingernails, consistent with psoriasis, dry scaling erythematous patches on the elbows and knees, and synovitis with fusiform swelling on the left, second, and third proximal interphalangeal joints, and the right third proximal interphalangeal joint. The left ankle is swollen and painful to motion. There is full but painful range of motion of his lumbar spine with right sacroiliac tenderness. So the basic points here is that in this particular case are as follows. You have a young man with back pain, which is inflammatory, getting better with which is inflammatory, getting better with exertion. That is a seronegative spondyloarthropathy, until proven otherwise. All right? So let's go to the radiology. Okay, so what are the findings here? What are the findings here? This is the dial. So you can actually see here fibrosis of the joints and fusion of the vertebral bodies. The intervertebral space is sort of fibrosed, and this is consistent with an ankle with a seronegative spondyloarthropathy. Now this is the dagger sign. You can actually see the fibrous sheath here, a fibrous bundle of fibrinous tissue running up and along the spine. And that sort of looks like a dagger, right? It's just like a little stake or a little spike. It's actually called the dagger sign. The arrows are. This is what? Psoriasis, okay? This is the white, scaly manifestation on the extensor surface of the upper extremity consistent with psoriasis. What's this? Okay. This is a bamboo spine. It's a lateral view of the spine, and this is a bamboo spine. What's this? Okay, this is pustular psoriasis. Where psoriasis not so much scales, but again on the extensor surface. So if you see a picture like this with a history of arthritis, history of back pain, think about psoriatic arthritis. What's this? This is a sacroiliitis. You see the fibrosis and the fusion and the lack of the joint space in the hip joint. And what's this? It's a tough one. What's this? What's this? What are three primary manifestations in the seronegative spondyloarthropathies that we don't get in any other arthritis? What? We can actually, there's something called enthesopathy, right? And that's basically inflammation of the tendon rather than the joint where it inserts into the bone. And what are the three manifestations? You can get dactylitis, you can get swelling of the fingers. You can get Achilles tendon swelling, and you can get plantar fasciitis. And again, the distinction there is that the joint is not that which is inflamed, but rather the point at which the tendon from the muscle inserts into the bone becomes inflamed. That's known as enthesopathy. So here, this is a picture of dactylitis. You can't really see it that well, but there is significant finger swelling associated with the arthritis. Significant finger swelling associated with the arthritis, or swelling of the soft tissues around the bone. I don't know if you can appreciate that, but you sort of see here the dactylitis, which is sort of characteristic of the seronegative spondyloarthropathies. All right, let's go on to the next. Here is the last thing. This is the tram track sign. And if you see here, fibrinous tissue on each side with fibrous fusion in the middle, sort of looking like a railroad track going up the spine, consistent with seronegative spondyloarthropathy. Okay. Case 9. A 50-year-old woman comes to the office with complaints of pain after working at a computer as a secretary for many years. Her fingers become numb, especially her thumb and her first 3 fingers. Along with her paresthesias, she complains of weakness in her hand. Physical examination shows thenar muscle atrophy. Tinel and Phaleine sign are positive. The remainder of the physical exam is unremarkable. So what is the most likely diagnosis in this particular case? Okay, carpal tunnel syndrome. Why? Why is carpal tunnel syndrome the most likely diagnosis? Okay, so she has pain in the wrist and paresthesias in the hand in the distribution of the median nerve. Now, what is the pathophysiology of carpal tunnel syndrome? Right, so it's basically expansion or basically compression of the median nerve within the carpal tunnel, causing these paresthesias and causing the paresthesias and causing the muscle atrophy in the hand. Now, are there systemic diseases that can cause carpal tunnel syndrome? Diabetes. What else? hypothyroidism. What else? Acromegaly. Okay? So you always have to consider systemic disease as a cause of the carpal tunnel syndrome. Now, most commonly, you'll get a patient like this who uses their hands all day for many years and then gets carpal tunnel syndrome. So the most common cause of carpal tunnel syndrome is, sort of chronic activity at a computer. Construction workers get carpal tunnel syndrome. Chronic use of the hands in their work for many years causing the carpal tunnel syndrome. However, there are diseases that can cause carpal tunnel syndrome, like acromegaly, like hypothyroidism, and like diabetes. And you have to consider these diagnoses when you make the diagnosis of carpal tunnel syndrome. Now, do patients get better? Let's say a patient like this came in, and she was hypothyroid, and you treated her hypothyroidism. Would treatment of her hypothyroidism or her diabetes or her acromegaly actually make her carpal tunnel syndrome better? It generally does not. So unlike other diseases where you treat the secondary cause, it improves the symptomatology, carpal tunnel is a little bit of an exception. Treating a secondary cause, though it's recommended, the evidence that it actually improves symptoms in patients with carpal tunnel syndrome is limited. So you're going to treat the secondary cause if it's there, but it's not necessarily going to improve the patient symptomatically. Now, how do we treat carpal tunnel syndrome? Okay, hand splinting. What medications have actually been studied in the treatment of carpal tunnel syndrome? What? Okay, NSAIDs. What else? Prednisone has been studied. Even PO prednisone has been studied in the treatment of carpal tunnel syndrome. Diuretics as well, and vitamin B6. Okay? So, what medications have actually been shown to improve symptoms in carpal tunnel syndrome? The idea behind giving diuretic therapy, by the way, is to try to, like for example in glaucoma where we have high pressure, wherever there's high pressure, if we take out the water from that area, maybe the pressure will go down and the symptoms will improve. The same principle applies in glaucoma. If there's high pressure intraocularly, we'll reduce that pressure by giving diuretics. So in carpal tunnel syndrome, it was thought that if you give diuretics, you'll actually improve the symptoms. But the evidence that diuretics actually work, not really there. NSAIDs, the evidence that they actually improve symptoms in carpal tunnel syndrome, not really there. Vitamin B6 in terms of improvement of symptoms, not really there. However, PO prednisone has been shown to improve symptomatology in patients with carpal tunnel syndrome. So if you were asked a question on the board, what is the one PO medication that will improve symptoms in carpal tunnel syndrome? Believe it or not, the answer is steroids. Not NSAIDs, not diuretics, not vitamin B6. It's steroids. If you were asked, what's the best initial treatment for patients with carpal tunnel syndrome? The answer would be splinting, hand splinting. The answer would be hand splinting. Now, if a patient presents with carpal tunnel syndrome and basically the treatment of choice is prednisone if it's PO and splinting if it's not. The best initial treatment is the prednisone, or is the hand splinting, and the best PO treatment is the prednisone. Now, when do you go for surgery in carpal tunnel syndrome? What? When the patient's refractory to medical treatment, or if there is constant pain for more than a year, or if there's weakness and muscle atrophy, you may advocate a more aggressive approach. Now, is there anything that you can do between medical therapy and between surgery? If you don't want to give PO prednisone, but you don't want to go to surgery, what can you do? you can actually give steroid injections into the carpal tunnel, and that's been shown to improve functionality and to improve pain. So medical therapy, the only proven effective medical therapy is prednisone PO. Hand splinting is the best initial therapy. And intracarpal tunnel injections of steroids is a good thing to do before sending the patient to surgery. And you send the patient to surgery when the patient's having refractory pain, constant pain, weakness or atrophy of the thenar muscles. Now, in terms of surgery, there's a number of approaches. There is the open or classic sort of incisional approach where they open up the carpal tunnel and they dissect to release the pressure. There is an endoscopic procedure where they actually go into the carpal tunnel endoscopically and try to decompress the median nerve. And there's also a limited open decompression procedure. Now, between those three surgical procedures, it is the limited incision open decompression which is the preferred choice. The limited incision open decompression, which is the preferred choice. So, here you see a nice little diagram of the carpal tunnel and the median nerve coming through the carpal tunnel. And you see it affects the thumb, the first three fingers, and that's where the paresthesias go. And here's a diagram of the carpal tunnel sort of cut through the wrist. And you can see the median nerve and the transverse carpal ligament. And when the bones and there's a compartment, and when compression occurs, you can actually get carpal tunnel syndrome. Now, how sensitive is physical exam for the diagnosis of carpal tunnel syndrome? Phalein sign, Tinel sign. Phalein is where you bend your hands backward and you get the tingling, and Tinel sign when you tap on the carpal tunnel and you get the paresthesias in the appropriate distribution. How sensitive and specific are those signs for the diagnosis? Not really sensitive and not really specific. So how do you make the diagnosis of carpal tunnel syndrome? Electromyography, right? So you're going to assess the conduction along the median nerve. You're going to assess the conduction along the median nerve. So let's go on to the next case. A 35-year-old woman comes to the office with complaints of low back pain after a weekend of vigorous physical activity. Her back is extremely stiff with increased pain on mobility. She finds most comfort when she's laying flat. There is no history of fever, incontinence, or saddle anesthesia. There is no prior history of chronic back stiffness. Physical examination shows symmetrical decreased range of motion in all planes of the lumbar spine, including flexion, extension, and lateral bending and rotation. Okay, so let's look at the history. You have a 35-year-old female who comes to the office with complaints of low back pain after being involved in vigorous physical activity over the weekend. Now, let me ask you a question. When you're approaching a patient to back pain, what is the initial question or the initial sort of question that you have to answer for yourself when evaluating any patient with back pain? Trauma, yes, but more general than that. What? Occupation. I'm asking a philosophical question. Patient comes and asks you and says they have back pain. Now, what is the most important thing that you have to differentiate? What's the most important question that you have to ask yourself about this patient with back pain? Okay. Is all back pain the same? Or is some back pain worse than others? Meaning, can a patient with spinal cord compression and metastatic breast cancer have back pain? Okay. And can a patient with muscular strain have back pain? Okay. So, is one more emergent than the other? Is one more of an emergency, one more of an issue than the other one? right? The answer is yes. So you really have to answer for yourself. Patients who come in with back pain, am I dealing with a neurologic emergency? Or am I dealing with chronic muscular, osteoarthritic, whatever you want to call it, chronic non-emergent back pain? And that's a very important question, right? Because it's going to determine how is it going to change your management, whether it's an emergent back pain or whether it's non-emergent back pain. Well, it's going to change your management in terms of whether you're going to send the patient for imaging or not. It's going to change your management in terms of whether you're going to ask for a surgical consultation for emergent decompression. It's going to change your management possibly about whether you're going to give the patient steroids or no steroids when you're evaluating or when you're treating this patient. So when you have a patient with back pain, you really have to ask yourself, am I dealing with a spinal cord compression? Am I dealing with a medical emergency and back pain? Or am I dealing with chronic it's back pain, but, here's some Tylenol, go home and call me in a couple weeks. Right? It's an important question. Now, how do we differentiate? How do we make that differentiation? Let's start with history. So what facts on the history would make you feel that it's a little bit more emergent, that you wouldn't be so comfortable about this back pain? What? Incontinence, okay? So if there's a history of urinary incontinence, fecal incontinence, sexual dysfunction in males, an inability to get an erection, you're very, very, very concerned that there is a spinal cord process occurring. What else on history? What else on history? Okay, bilateral lower extremity weakness. If a patient comes to you and says to you, doctor, I have back pain and I can't get up because my legs are weak, and I have bladder incontinence and I have bowel incontinence and I have saddle anesthesia and I can't have sex with my wife, then you have to be very concerned that the patient has an acute spinal cord compression. So that's another important point in history. What else on history is important? What else? A history of carcinoma. Any patient who comes in with a history of breast cancer and back pain, prostate cancer and back pain, lung cancer and back pain. Those are the most common cancers that metastasize to the bone. But any cancer, lymphoma and back pain. Colon cancer and back pain. Cancer and back pain is no bueno. It's very, very bad. And you have to assume that this back pain is malignant and threatening, and you have to evaluate that patient with an imaging study. A history of bacteremia and back pain. Patient had endocarditis 5 weeks ago, was treated, went home, comes back with back pain. What's your diagnosis? What's your diagnosis? Patient had gram-negative sepsis secondary to cholecystitis with E. coli bacteremia, was treated, comes back a number of weeks later with back pain. What's the most likely diagnosis? Abscess. Osteomyelitis or abscess. So abscesses, presence of fever, history of bacteremia, these are important points when evaluating a patient with back pain. Because if the patient has an abscess compressing on the spinal cord, that's no good. And you may need emergent surgical intervention, and you may need to treat that patient much more aggressively than the patient who doesn't have that history. So if a patient has fever on exam, has point tenderness on the back, a history of bacteremia, consider epidural abscess as a cause of the back pain. What else can cause, what other kind of emergencies can cause back pain? Epidural hematomas. If there's a history of trauma, sudden onset of back pain, lower extremity weakness, with bladder incontinence, bowel incontinence, sexual dysfunction, saddle anesthesia, you have to consider an epidural hematoma as the cause. Now, patients can also have triple A's. Aortic aneurysms, abdominal aortic aneurysms can sometimes cause back pain. And if they have risk factors for atherosclerotic disease, you should consider the diagnosis when evaluating a patient with back pain. You should consider the diagnosis when evaluating a patient with back pain. So what on a physical exam can help us differentiate between emergent back pain and non-emergent back pain? Well, we said weakness, hyperreflexia of the lower extremities bilaterally, and sensory changes. Okay? Now, if a patient has a radiculopathy, right, you can actually evaluate which nerve roots are involved. All right? And you can do that by evaluating the motor, the sensory, and the reflexes. Right? And, the mnemonic that I use basically is like this. This is L4. This is motor. L5 is my big toe, if you can see it in my shoe. And S1 is the version of your foot. L4, L5, S1. It's a little dance. L4, L5, S1. Right? That's motor. So if you have a radiculopathy, you'll only have involvement of one nerve root. Right? Sensory is basically like this. L4, L5, S1 is the lateral side of the foot. L4, L5, and S1 is the lateral side of the foot. In terms of reflexes, L4 is your patellar reflex. L5 has no reflex loop. And S1 is your ankle jerk. All right? So if you have patients who come in with back pain and have involvement of multiple nerve roots, meaning they have weakness in L4 and sensory loss on the lateral side of their foot, you have to be a little bit more aggressive with those patients because they have multiple nerve root involvement, and you may send those patients for imaging studies earlier than other patients who have one single root, who have a single root involved. So, when you're looking at a patient with back pain, look at the history, look at the physical exam, make an assessment about whether this is emergent spinal cord compression or cauda equina syndrome. You do that by looking at the history, doing a physical exam, and then you're going to make a decision about how to manage these patients. All right? So let's look at her history. She has complaints of low back pain after a weekend of vigorous physical activity. She has extremely stiff back. She's most comfortable when she's lying flat. When she's lying flat. No history of fever. Epidural abscess is less likely. No history of incontinence, so it doesn't look like she has a spinal cord compression. No history of saddle anesthesia. So those are important points. What they're telling you is that this is not emergent back pain. I'm not worried that this patient has a spinal cord compression or a cauda equina syndrome. And there's no prior history of chronic back stiffness, and there's no prior medical history of breast cancer or of lung cancer or of prostate cancer, especially because she's a 35-year-old woman. All right? So let's go to physical exam. On physical exam, you have shows a symmetrical decreased range of motion in all planes of the lumbar spine, including flexion, extension, lateral bending, and rotation. There are no sensory or motor or reflex changes in her lower extremities. She doesn't have motor deficits involving more than one roots. She doesn't have hyperreflexia. She doesn't have bilateral lower extremity weakness. No focal neurological signs. And the straight leg test is normal. There's also tenderness along the lumbar paraspinal muscles bilaterally along the spine. So given the discussion that we've had before over the last 10, 15 minutes, does this look like emergent back pain? Is this a medical emergency? No. She has no history that predisposes her to anything in the spine that would affect her. And on physical exam, there's no focal neurologic deficit whatsoever. So you're pretty confident at this point that this woman is pretty safe. Does she need an imaging study? No. What does she need? Analgesia and as much activity as she can tolerate. Bed rest has actually not been shown to improve back pain. Right? 2 days. Okay. But generally, you encourage the patients to do as much activity as they possibly can. Right? So they should be active, they should get analgesic medication, and they should move around as much as they can, as much as their back pain will allow them to do. So the main point in this case is to recognize why this back pain is non-emergent, why you're not sending the patient for an imaging study, and when you would send a patient with back pain for an imaging study, and when you would consider that back pain to be emergent. Okay, that's it. Thank you very much.